everyone. So we'll be winding our class of ABG with the disorders. First, we'll start off with the metabolic acidosis. So we have studied till 4. So metabolic acidosis. So metabolic disorders, pH and PCO2 goes in the same direction. pH decreases less than 7.35. PCO2 also decreases less than 35 as a compensation. HCO3 decreases because pH is going down. With respect to compensation, we know PCO2 decreases, respiratory alkalosis occurs. So we calculate the compensation using the Winter's formula of 1.5 into bicarbonate plus 8 plus or minus 2, which gives the estimated level of compensation. Calculate the anion gap in metabolic acidosis. We know the anion gap is calculated by sodium. We add the cations, then subtract them from the anions, and we get 12 plus or minus 4 with an average of 10 to 12. Collected anion gap. See, this is an extra point. See, the anion gap can decrease by 4.5 for every 1 gram per deciliter decrease in albumin levels. So, after calculating the anion gap, the result what we get is either it is a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. What is high anion gap metabolic acidosis or HAGMA? HAGMA is seen in certain conditions like lactic acidosis, ketoacidosis, that is diabetic ketoacidosis, starvation, or alcohol ketoacidosis. Toxins like use of ethylene glycol, propylene glycol, methanol or salicylic poisoning, pyroglutamate acid poisoning, then also in certain renal failures. See, we can remember the examples using mnemonic as Kussmail. K for ketoacidosis, U for uremia, S for sepsis, S for salicylase, M for methanol, A for alcohol, L for lactic acidosis, E for ethylene glycol. There's also one more mnemonic, CAD mud pies. C with carbon monoxide cyanide congenital heart failure, A with aminoglycosides, T for theophylline toluene, M for methanol, U for uremia, D for diabetic ketoacidosis, all the ketoacidosis come here, starvation alcohol, P for paracetamol poisoning, phenmorphine paraldehyde, and I for use of iron, isonic acid, inborn aversive metabolism, lactic acidosis, ethanol, ethylene glycol, and salicylates. If we add up here, it becomes mud pilers, which gives rhabdomyolysis. Of normal anion gap metabolic acidosis, the examples. And here the examples are divided into two, one that have a tendency for hypokalemia and one have a tendency for hypokalemia. So hypokalemia, we have subsiding diabetic ketoacidosis, early uremic acidosis, early obstructive uropathy, renal tubular acidosis type 4, hypoaldosteronism, infusion or injection of HCl, NH4Cl, lysine hydrochloride, arginine hydrochloride, potassium sparing diuretics. With tendency for hypokalemia, you have renal acidosis type 1 and type 2, acetazolamide, acute diarrhea with loss of bicarbonate of potassium, ureterosigmoidostomy, obstruction of artificial ileal bladder, dilution acidosis. So if you can see, renal tubular acidosis comes under normal anion gap metabolic acidosis. Now we come for metabolic acidosis. Concept. pH and PCO2 goes in the same direction. pH more than 7.45, PCO2 more than 45 as a compensation. Bicarbonate, as we all know, will be more. Expected compensation, for every 1 increase in bicarbonate, you get a 0.4 increase in PCO2. For every 10 increase in bicarbonate, you get a 7 increase in PCO2. That what metabolic alkalosis does. That is a net gain of bicarbonate or the loss of non-volatile acid from the body. These are the sites of a nephron where you're getting absorption of bicarbonate. In proximal tubule, there will be 80 to 85% absorption, collecting like about 3 to 5% absorption. And also in loop of Henle, you get 10 to 15%, the ascending loop. You all know in metabolic acidosis, hypokalemia occurs. That is all K loss. Alkalosis, all K loss. That is, there will be a shift of hydrogen ions outside the cells that metabolic alkalosis does. So, as a compensation, there will be potassium shifting inside the cells, which can eventually lead to hypokalemia. Hypokalemia and metabolic acidosis, which can, so metabolic alkalosis can directly or indirectly induce renal potassium. So either it can shift the potassium into the cells or it can cause a renal potassium loss, vomiting, use of diuretics, and mineralocorticoid excess. That is how in metabolic alkalosis potassium loss occurs. You bulimia in metabolic alkalosis, and whether we have a volume loss or not. So when an abnormal chloride levels is seen in our ABG, there will be a proportional degree of hyponatremia, that is indicating a volume loss. When a patient vomits, so when a patient has a good volume loss, chloride levels also gets vomited out. So what compensation does our body does? You just have to check his urine chloride levels. If the urine chloride levels is less than 20, that means the body is trying to uh, absorb whatever chloride it can, and it shows the patient has a volume loss. So hypochloremia, just as I said in this examples of metabolic alkalosis, the most important examples you need to remember in case of metabolic alkalosis is volume loss, that is vomiting extra, then use of diuretics, then something that imitates the use of diuretics, that is inherited disorders, Bartter and Gentleman. All other examples actually come secondary because these two are actually very important to us in our OP and in emergencies. Phospholic acidosis. Let's use a concept here. pH and PCO2 goes in the opposite direction. pH is less than 7.35. PCO2 will be more than 45. Metabolic acidosis and respiratory acidosis. So PCO2 and pH goes in the opposite direction. As a compensation, bicarbonate also increases. We have acute respiratory acidosis and chronic respiratory acidosis. In acute respiratory acidosis, for every 1 rise in bicarbonate, there will be 10 rise in PCO2. In chronic respiratory acidosis, for every 3.5 rise in HCO3, we get a 10 rise in PCO2. These are all the examples for respiratory acidosis. We have central deposition of respiratory drive, that's use of drugs, CNS lesions, trauma, strokes, etc. Neuromuscular, spinal cord lesions, then tetany, poliomyelitis, ALS, myasthenia gravis, OP poisoning, botulism, etc. Upper airway obstruction, aspiration, chest wall also, trauma, that's flail chest, paralysis, etc. Pneumothorax, extra lung parenchyma, cardiogenic pulmonary edema, ARDS, pneumonia, other circulatory shock, sepsis, malignant hypothermia, CO2 insufficient in the body. Cause of chronic hypocapnia, again, central depressive drive, primary alveolar hypertension, neuromuscular, all this comes, chronic neuromyopathies, poliomyelitis, etc. Chest wall, structural chest wall abnormalities, kyphoscoliosis, obesity, thoracolplasty, then large pleural effusions, long-standing ILDs, then persistent asthma, COPD, etc. Respiratory alkalosis, the last topic. So putting in the concept, pH and PCO2 goes in the opposite direction. pH is more than 7.45, PCO2 is less than 35. So that is respiratory alkalosis. What here is that HCO3 will be less than 22 milliequivalents per liter, trying to get the pH, the normal values. What the expected compensation? We get acute and the chronic respiratory alkalosis. Acute respiratory alkalosis, bicarbonates falls by 2 and there will be 10 millimeter decrease in PCO2. In chronic, bicarbonates falls by 5 and there will be 10 millimeter decrease in PCO2. What are the examples we get for respiratory alkalosis? Hypoventilation, the perfect choice. Psychogenic, central neurological hypoventilation. Hormonal, infectious, thermal hyperapnea, intoxications, chemoreceptors, receptors, mechanical ventilation, extracorporeal CO2 removal. Whatever conditions that wash out as a CO2 can cause respiratory alkalosis. Panic, hysteria, etc. Most commonly, brain injuries, invasive brain tumors, brain infarcts, increased progesterone levels in pregnancy and cirrhosis, meningitis, fever and hypothermia. It also does it. Salicylates and dopamine, and peripheral like hypoxia, pulmonary diseases, high altitude, pulmonary edema, ARDS, asthma, iatrogenic, that is excessive removal. So thank you. Here we'll be winding our topic of AFG classes. Hope you like it. Please subscribe and share the channel.